The purpose of this video is to illustrate a technique of laparoscopic nephrectomy for giant polycystic kidneys and demonstrate its feasibility and safety. The indications for laparoscopic nephrectomy in patients with polycystic kidney disease are the same as for open surgery and include pain, infection, bleeding, and pre-transplantation. This patient is a 56-year-old man in renal failure secondary to autosomal dominant polycystic kidney disease. He is currently on peritoneal dialysis and requires nephrectomy for both pain management and to increase abdominal space accommodating the transplant kidney. CAT scan confirms massively enlarged kidneys extending from the liver to pelvis. The key points for laparoscopic right nephrectomy include left lateral decubitus position, medial mobilization of the colon with attention to a thin colonic mesentery, volume reduction of the kidney, and identification of the ureter, renal artery, and vein. Patients are placed in a lateral decubitus position with the table flexed and kidney bolster raised. The abdomen is prepared and draped normally. A 12 mm trocar is placed through the base of the umbilicus using a direct open technique. A 15 mm of mercury CO2 pneumoperitoneum is established and a 10 mm 30-degree laparoscope is used. Upon insertion, a large polycystic kidney is found. Remaining ports are placed under direct vision after the skin and fascia are injected with local anesthetic. Final trocar placement shows 12 mm ports at the right iliac fossa and umbilicus, as well as a 5 mm subxiphoid port. Peritoneum is incised, facilitating mobilization of the colon medially. Multiple cysts come into view. It is important to dissect directly on the cysts so as not to injure the colonic mesentery, which is often stretched and thin. Once the colon is sufficiently mobilized, the renal volume can be reduced with the help of a powerful beveled suction aspirator designed by a member of our team. Progressive renal volume reduction greatly increases working space and facilitates future identification of renal structures. To date, we have had no complications from minor spillage of cyst contents. Fluid is collected with strong -70 mm of mercury suction in order to minimize spillage. Volume reduction promotes further dissection, increasingly making the kidney more manageable. Eventually, the kidney is light enough to be lifted, facilitating exposure of hilar structures. The ureter is identified and is then clipped and divided. The renal artery, followed by the vein, are treated in a similar fashion. The kidney is completely freed and is placed on the liver prior to removal. Cyst fluid and blood are cleared, and then an extraction bag is inserted for kidney removal. The kidney is extracted piecemeal without expansion of a trocar wound. Wounds are closed normally and steri tapes are applied. To date, we have performed 10 laparoscopic nephrectomies with a median kidney size of 24 centimeters on preoperative CAT scan. There were no conversions nor intraoperative complications. There was one thrombosed arm arterial venous fistula that occurred postoperatively. The average length of hospital stay was 2.6 days. In conclusion, laparoscopic nephrectomy is feasible and safe for giant polycystic kidneys. Advantages include low complication rate, short hospital stay, minimal pain, and superior cosmesis.